Hi, my name is Dr. Bill Gray. I'm with the Lankenau Heart Institute and Mainline Health just outside Philadelphia, Pennsylvania, USA. And the title of the study is the Disrupt PAD3 trial. The rationale of the study is actually an interesting one. We know that in many of the patients that we perform lower extremity revascularizations for, that calcium is a significant burden in terms of our ability to treat the patient. That is, calcium makes it difficult to dilate the vessel. When we do try to dilate the vessel, it can lead to perforation, major dissection, and an incompletely dilated lesion. So this trial was meant to test a device which was specifically designed for calcification. That is the Shockwave intravascular lithotripsy, or IVL. And the IVL trial, the IVL study was meant to select patients who had heavily calcified lesions and assess whether or not IVL was more effective in the acute setting for procedural outcomes than standard balloon angioplasty. The study design was randomized 1-to-1, and the critical inclusion criterion, as I mentioned, was that you had to have moderate or severe calcification, as judged by certain parameters around the length of calcification and how much calcium was present on both sides of the vessel. It's an accepted standard definition of calcium. So patients had to have basically severe calcification to get into the trial. They had to have lesions that were 15 centimeters or less, or 18 centimeters, sorry, I should say 18 centimeters or less, or a total occlusion of 10 centimeters or less. The patients were randomized 1-to-1 to either IVL therapy or standard balloon angioplasty. They received those therapies, and then the endpoint of the trial, the primary endpoint of the trial, was assessed, which was procedural outcome. And the outcome was judged to be the achievement of a stenosis less than 30% residual without the presence of a severe dissection C grade or worse. So that was the endpoint of the trial. Now, many SFA trials have endpoints which are much longer, 1-year patency endpoints, and we will have those endpoints. They're secondary powered endpoints, which will look at patency, because what happens after that primary endpoint, patient went on to have an impact DCB treatment in both arms. And then and we're going to find out whether the use of IVL shows any differential effect in the antiproliferative therapeutic for DCB at 12 months. So it's an interesting trial. Primary endpoint in the lab, did we get the lesion open without dissection? Powered secondary endpoint, 12-month patency to see if DCB is augmented with IVL. The key results were that the primary endpoint was actually found to be better or superior for IVL as compared to POBA. There was more, there was about 2/3 of patients who achieved a stenosis less than 30% after IVL therapy, as opposed to about half the patients in PTA. And there was very few important dissections in the IVL arm, but quite a few C and D dissections and worse in the PTA POBA arm. So that was the main outcome of the trial. There were ancillary outcomes related to time of procedure, number of balloons, and so on. There were some differences there, but really those differences, which tended to be longer times in the IVL arm and more balloons in the IVL arm, are related to a prior generation of generator, which has now been upgraded and will probably cause those to be equal. From a safety perspective, and this is important because we all talk about efficacy, we want to know if the device worked, but from a safety outcome perspective, at 30 days, IVL showed no outcome issues related to perforation, distal embolization, and need for clinically driven TLR or thrombosis. So as compared to POBA, actually it was numerically less. Those safety outcomes were numerically less for IVL than they were for POBA. So it turned out to be a very effective therapy, but also incredibly safe. especially as we compare it to things like atherectomy. But in addition to having lower dissection rates and greater lumen gain, we also saw far fewer stents placed in the patients with IVL as compared to balloon angioplasty, about 3 times less stent implantation for significant dissection or residual stenosis. Well, the conclusions from the trial are that IVL therapy is easily administered, it's highly effective, and very safe for the acute outcome of lesion reduction in the lab. And this is especially as compared to PTA, which was the standard of care prior to IVL. Well, the big next step is to gather the data at the 12-month powered endpoint for patency. As many of the viewers know, patency in DCB and heavily calcified lesions has been called into question based on Finelli and others' work. And so it'll be very interesting to see if we have a patency advantage, that is, does IVL enable DCB to be more effective in these calcified lesions by changing the nature of the calcified plaque.